Good morning. Uh, So it looks like post-Holi effect is still going on. It's very thin attendance. So, but still it's 8 o'clock. We'll start the CGR. And today's presentation by the uh, Apex Trauma Center, and it is presented by the Specialty of Oral and Maxillofacial Surgery. And they have a vast experience in various trauma. So today they are going to talk about the lateral mid-face fracture. For this, I will invite the faculty, Dr. Kuldeep Vishkarma, to start the session.
Uh, Good morning, everyone. I am Dr. Kuldeep, and I am additional professor in the specialty of oral and maxillofacial surgery at Apex Trauma Center. So, in today's CGR, we will be speaking on the topic of lateral midface fracture and their management. But before we begin, I would like to provide a brief context about our specialty and our departmental activities. So we come from dental background, but our specialty differs significantly from the core branches of dentistry. Uh, while other dental branches mainly deals with teeth and their supporting structures, we mainly deal with the surgical aspect of diseases and injuries of jawbone, face, and oral cavity. So we started functioning in year 2018, and so far we have managed more than 12,000 patients in our OPD. This is our OPD census showing steady increase in the number of footfall of the patient over the past few years. So this data includes both the maxillofacial trauma follow-up patients and various consultations, dental consultations from other departments of our institute and referrals. So we perform minor oral surgical procedures in our OPD, which extends from simple to complex extraction of teeth, management of some closed reduction of maxillofacial fractures, and also involves minimally invasive procedures of temporomandibular joint disorder and other minor surgical procedures. So we provide round-the-clock AD services, and where we manage mainly soft tissue injury repair, stabilization of maxillofacial fractures, and control of maxillofacial bleed. This is our OT census. We have managed more than 541 cases till date, and this slide depicts a steady increase in the number of OT cases. So we manage both the trauma and non-trauma cases at our center. The non-trauma cases include cyst and pathologies of the jawbone, management of TMJ and callosis, oral submucous fibrosis, silolithiasis. However, most of the chunk of our practice include maxillofacial trauma cases. So this slide depicts the spectrum of maxillofacial trauma that we had operated upon, uh, uh, which constitute around 475 cases till date. Isolated soft tissue injuries constitute around 14% cases. However, most of the cases were with fracture of bony facial skeleton. In these fractures, most of the fracture, around 45% cases, include lateral midface fracture. So this is the lateral midface. Because of its prominent position over the face, this is most commonly get fractured and resulting in severe aesthetic and functional deformity. And these fractures are notorious for their suboptimal outcome if not managed properly. So in today's CGR, we will be presenting the clinical features, clinical presentation, fracture pattern, management strategies, and the role of virtual surgical planning and 3D printing in the management of these injuries. So now I would like to invite Dr. Diksha to proceed with the presentation.
Thank you, sir. I'll proceed with the presentation. The topic itself, the lateral midface fracture management, principles and techniques. A brief disclaimer before proceeding to the further slides. This presentation includes the clinical photographs of patients involving the facial structures. Due to the nature of the maxillofacial trauma, it is often not feasible to adequately demonstrate the surgical outcomes with facial or ocular blurring. Informed written consent was obtained from all the patients for the use of their clinical images, strictly for academic, educational, and scientific purposes. The lateral midface comprises of the zygomatic bone, the cheekbone as we all know, along with the zygomatic arch. This bone articulates with the frontal bone, the maxillary bone, the zygomatic arch, and the sphenoid bone. It is the second most common midface fracture after the nasal bone fractures. The zygomatico-maxillary complex fractures are mostly due to osseous disruption of the malar eminence at 4 buttress sites, including the zygomatic arch. The prominence of the malar eminence places this structure at a greater risk for fracture. The etiology includes high-impact facial trauma. In Indian subcontinent, the most common etiology is the road traffic accidents. In other countries, the most common etiology is interpersonal violence, followed by road traffic accidents, then fall, and sports injuries. Anatomically, the zygomatic bone articulates with the maxillofacial skeleton at these 5 articulation points: the frontal bone, the infraorbital rim region, the zygomatico-maxillary buttress, the zygomatic arch, and forming the lateral orbital wall. The zygomatic arch, well, not essentially an arch itself, it's quite straight. It has a very thin articulation. Anteriorly, it is formed by the temporal process of the zygomatic bone, and posteriorly, it is formed by the zygomatic process of the temporal bone. It is a very delicate connection. Thus, it fractures very frequently with minimal force. The length of the zygomatic arch is a key parameter for determining the sagittal projection of the zygoma. The broad attachment of the masseter muscle becomes the major deforming force in the zygomatico-maxillary complex fractures, which we'll see in the further slides. Coming to the muscle attachments, the medial and the inferior surface of the zygomatic arch is the site of attachment of the masseter muscle. The 2 major group of muscles which are attached to the zygoma are the muscles of facial expression and the muscles of mastication. The muscles of mastication include the masseter and the temporalis muscle, along with its fascia. The muscles of facial expression include the zygomaticus major, zygomaticus minor, and the levator labii superioris. In clinical presentation, the patient presents with early clinical signs and symptoms, which are as follows: the gross facial asymmetry and edema, which is evident in this image, the periorbital edema along with periorbital ecchymosis, the subconjunctival hemorrhage, and chemosis. After the edema subsides, we can see some late clinical features. There is a gross facial asymmetry in the midface region, which we can see in this image too. A depressed or flattened malar prominence depicted by the arrow, a flattening, hollowing, or broadening over the zygomatic arch region, and a palpable bony step at the infraorbital and lateral orbital margins. The ocular or ophthalmic symptoms include pseudotosis, which is caused due to recession of the globe and deepening of the supratarsal fold, increased scleral show, and when the fracture fragment is above the level of the lateral canthal attachment of the lateral canthal ligament, there is a downward slant of the palpebral fissure, which is called as the antimongoloid slant. Then there is vertical shortening of the lower eyelid, known as ectropion. It is essentially due to the loss of muscle tone. Then there is hypoglobus. It is a globe level disparity, which can be seen in this image. Enophthalmos, which is inward sunkening of the eye, diplopia, the double vision, motility restriction due to the herniation of the contents into the maxillary sinus. The most commonly muscle involved is the inferior rectus muscle, which causes a restriction in the superior gaze or upward gaze. Partial or total blindness. As we have seen previously, zygomatic bone forms the lateral orbital wall, part of the lateral orbital wall. So whenever there is an injury of the zygomatic bone, it involves the periorbital structures. According to the American Association of Ophthalmology, they have recommended an 8-point ophthalmology examination whenever periocular structures are involved. This includes the assessment of visual acuity, where we assess how clearly a patient can see. It is done using Snellen's chart. Then pupillary response is assessed to see the equality, roundness, and reactivity to the light in both the pupils. Extraocular muscle motility is assessed in both the eyes and individually in each eye using duction tests. Intraocular pressure is seen with Goldman tonometry test. The confrontational visual fields are assessed for peripheral vision. The external examination includes the inspection of the external eye structures, such as eyelids, conjunctiva, and sclera. The slit light examination, which uses a special slit lamp microscope to examine the cornea, iris, lens, and the anterior chamber of the eye. Lastly, the fundoscopic examination for examining the retina, optic disc, and the blood vessels. The major sensory supply to the midface or the facial region is given by the trigeminal nerve. And the most commonly injured nerve is the maxillary division of the trigeminal nerve. Following are the 3 nerves and their supply, which are mostly affected in the zygomatico-maxillary complex fractures. First is the zygomatico-temporal nerve, which supplies the lower lateral orbital rim region, the anterior temporal region, and the frontal region. Then there is zygomatico-facial nerve, which supplies the malar eminence and the region of the cheek. And lastly is the terminal branch of the maxillary division, which is infraorbital nerve, which supplies the lower eyelid, the upper lip, ala of the nose, and the lateral side wall of the nose. The oral symptoms include ecchymosis of the gingivobuccal maxillary sulcus and occlusal discrepancy, which can be seen in this image, and restriction of the mandibular opening, that is trismus. This restriction or trismus is usually due to the impingement of the fractured zygomatico-maxillary complex bony fragment over the coronoid process of the mandible. Then there are nasal symptoms, which includes the ipsilateral epistaxis, ipsilateral hemosynus. In the radiographic examination, we have conventional radiography. Waters view and the submental vertex view were previously used a lot. They helped in identifying the displacement of the zygomatico-maxillary complex fractures. Whereas the disadvantage of these radiographic techniques was that they form a clouding of the fractures and there is superimposition of the structures, causing inability to see a few fracture segments. Then we have advanced radiography, which is computed tomography. It is the gold standard. Here we see the fracture or assess the maxillofacial skeleton in 3 planes, that is the coronal, axial, and the sagittal view. In the coronal plane, we can see the orbital floor deformities, the infraorbital rim and infraorbital canal obliterations, the orbital margins, disruption of the orbital margins, the zygomatico-maxillary buttress region, the posteromedial bulge of the zygoma. In the axial section, we can see the malar prominence. There is a difference in the malar prominence, the zygomatic arch fractures, the lateral wall of the orbit, then the sphenozygomatic suture sites. In sagittal view, we can see the orbital floor obliterations, the posterior ledge of the orbit. A 3D reformatted view is also generated, which gives a spatial visualization to the displaced zygomaticomaxillary complex fractures in comparison to the other maxillofacial skeleton present. Following are the different classifications which were given in different years. The first was North and Knight, Knight and North in 1961, Rowe and Killy, Larson and Thompson, Rowe and Williams by Manson, Zing and colleagues. But the most commonly followed classification is by Rose. In this classification, it is based on the stabilization of the fracture fragment after reduction. So first we have fractures which are stable after reduction. In this, we have fracture of the zygomatic arch, which is medially displaced. Then fractures along the vertical axis, which passes through the frontozygomatic suture and along the maxillary first molar. These can be inward, that is medially, or outward, that is laterally rotated. Then we have fractures which are unstable after reduction. These include fracture of the zygomatic arch, which is inferiorly displaced, and fractures which pass through, which are rotated along the horizontal axis, which passes along the infraorbital rim and the zygomatic arch. This rotation can be either inward medial upward or outward lateral downward. Then we have en-bloc fracture of the zygomatic bone, and lastly, the comminuted fractures of the zygomaticomaxillary complex. Coming to the indications of repair and timing of the surgery. The surgical outcome of the zygomaticomaxillary complex fractures crucially depends on choosing the right indication for intervention and the ideal time for the surgery. The ideal indications for the repair of ZMC fractures includes two basic components: the presence of cosmetic defect and presence of functional defect. The cosmetic defects include facial deformity, loss of lower eyelid support, ocular dystopia. The functional defects include the limitation of the mouth opening, sensory nerve deficit, and ocular movements. No intervention is recommended when the fracture is incomplete, undisplaced, or minimally displaced. When the indications are definite, early intervention is recommended. And when the indications are questionable, we wait for the edema to subside and operate by 7 to 10 days. In patients who have already compromised vision in the unaffected side, we refrain from operating as it may lead to further complications in vision in future. Coming to the principles of fixation, the zygomaticomaxillary bone is a 3D structure. It is formed by pillars. These are known as buttresses. These are thick bones which form the pillar of the zygomatic bone. These are 4 paired buttresses, horizontal and vertical buttresses. The reconstruction of these buttresses provides the transverse width to the face, the vertical height of the face, and the anteroposterior projection of the face. The goal is to achieve these 3 dimensions after the reconstruction of the zygomaticomaxillary complex fractures. Here I'll be telling the vertical buttresses which are essential for the reconstruction of the zygomatic bone. The first is the nasomaxillary buttress. Then we have the zygomaticomaxillary buttress, the pterygomaxillary buttress. In the horizontal buttresses, we have the infraorbital rim. The sequencing of these buttresses includes first, the reconstruction of the vertical height of the face, second, the reconstruction of the anterior dimension of the face, and then the width of the face. Coming to the determination of the necessity of fixation, it depends upon the post-reduction stability of the fracture. The post-reduction stability depends upon the fracture pattern and the degree of comminution. One-point fixation is mostly recommended in less severe injuries. It is mostly done at the zygomaticomaxillary buttress region as it is a strong bone and provides sufficient stability to the fracture site. It can also be done on the frontozygomatic suture site, but it requires an external incision, and the palpability of the implant is a major issue. Also, the short course in one plane makes this an unreliable point for fixation. After each step, the stability is checked by rocking the zygoma moderately. If there is no mobility, then one point fixation is done and closed. If there is mobility, element of mobility, more stabilization is required, and a 2-point fixation is done. One is done in the zygomatico-maxillary buttress, and the other can be done at infraorbital rim or the frontozygomatic suture site, depending upon the fracture pattern. Then we have 3-point fixation, which is done at the zygomatico-maxillary buttress, the frontozygomatic suture, and the infraorbital rim. It is done in the medium injury category, and the comminution zones at the infraorbital rim and zygomatico-maxillary buttress region. Lastly is the 4 and 5-point fixation. It is recommended in the severely dislocated and comminuted ZMC fractures, typically requiring wider exposures, mostly by the combination of anterior and posterior surgical approaches. Here, the plating is also done at the zygomaticosphenoid and the zygomatic arch region. Coming to the surgical approaches, we have 3 basic surgical approaches: anterior approach, superior lateral approach, and posterior approach. In anterior approaches, we have inferior maxillary approach. Here, an upper gingivobuccal sulcus incision is placed, also known as the Keynes approach. It gives a good exposure to the zygomatico-maxillary buttress region. Then we have anterior lamellar approaches, which provide a sufficient exposure of the infraorbital rim and the orbital floor. These incisions include subciliary, the subtarsal, and the infraorbital rim incisions. The posterior lamellar approaches, which also expose the infraorbital rim and the orbital floor. These approaches include the transconjunctival, the transcaruncular, and the transconjunctival with lateral canthotomy. Then we have superior lateral approaches, which expose the frontozygomatic regions. And these approaches include a lateral brow incision and the upper blepharoplasty type incision. The posterior approaches provide a good exposure to the frontozygomatic region, the zygomatic arch, the body of zygoma itself. These incisions include coronal incision, hemicoronal, and 3/4 coronal incision. The assessment of accuracy of reduction becomes an essential component in the intraoperative period. The C-arm is a device which is used. It gives a real-time, high-resolution X-ray imaging, but it has high radiation exposure and only 2-dimensional imaging is obtained. Also, it can only be used in the fractures of the zygomatic arch. Then we have intraoperative ultrasound. It is real-time imaging, gives immediate feedback, no radiation hazards, comparatively less expensive, and can be repeated. But the image artifacts and it is a disadvantage, and also it can be only used for the zygomatic arch fractures. Then we have the gold standard, that is intraoperative CT. It provides high-quality 3D imaging, especially useful for more complex and comminuted fractures. But the disadvantage includes high radiation exposure and high equipment costs. The latest is the intraoperative navigation or computer-assisted surgery. It provides increased precision and reduced surgical errors are seen, but the equipment cost is high and dependence on the preoperative image accuracy is also there. Coming to the complications, after operating the patient, we can see some early complications and late complications. The early complications include weakness of the facial nerve branches, enophthalmos, diplopia, ectropion, and increased scleral show, epiphora, and trismus. The late complications include implant infection, temporal hollowing, alopecia over the incision site, and implant palpability or exposure, and sinusitis. Some of the most representative cases done by our department will be discussed by Dr. Surinder sir in this clinical presentation.
Good morning all. I'll be continuing with the clinical case presentations. So starting with our first case. This is a 36-year-old gentleman who reported to us with a alleged history of physical assault That was the punch on his right side of face. He reported to us early, that is around 4 days after the trauma. And he had the chief complaint of restriction in his mouth opening and pain while he opened his mouth. Here in this clinical photograph, we can see the mouth opening was restricted around 14 millimeter. So CT was done, and on CT we can see the zygomatic body and arch was fractured with its inward displacement. And in this axial section, we can clearly see that it is impinging over the coronoid process. So the mouth opening was restricted due to this reason. So coming to treatment planning, as the patient reported only 4 days post-trauma, so there was minimal scarring and fibrosis. In such cases, there is good bony contact there and minimal periosteal disruption. So such fractures usually are not in need to get fixed. So only elevation of the depressed zygomatic arch via the upper gingivobuccal sulcus incision was planned in this case. And the reduction intraoperatively was checked using ultrasonography. Here we can see this before reduction, there was this bend in arch followed by straight arch. And intraoperative 35 millimeter mouth opening was achieved. This is pre and post-operative comparison of mouth opening. This is only 1 week after, so almost the mouth opening doubled. Now coming to our second case, this is a 37-year-old gentleman who reported to us with a history of road traffic accident, that is fall from bike. This patient, on the contrary, reported late to us at around 17 days after trauma, and he had the chief complaint again of restricted mouth opening. Also, additional findings in this patient included, as you can see with the dental staining, that the patient was a chronic tobacco chewer. So there was oral submucous fibrosis. So post-operative, we cannot expect a normal mouth opening of more than 4 centimeters. In the CT findings, we can see the right ZMC fracture with rotation along the vertical axis, and also here we can see the impingement of the fracture zygomatic arch with respect to the coronoid process of the mandible. So as the patient reported late, there is significant scarring and fibrosis. Such late operated cases are unstable after reduction. So 1-point fixation was planned in this patient with the same upper gingivobuccal sulcus incision intraorally. Here we can see before and after reduction of the arch, confirmed by ultrasonography, and this fixation done with a 1.5 milliplate system at the zygomatico-maxillary buttress region. Pre and post-operative comparison, here we can see the continuity of zygomatic arch is retained, and here we can see previously the step was there. And coming to mouth opening, the patient, post-operative, the patient has increased mouth opening of around 30 millimeter. Coming to our third case, a 42-year-old gentleman with etiology of road traffic accident and complaint of facial asymmetry and inability to close his left eye. So patient presented to us, this patient also presented to us late after facial edema subsided. The patient had a long and deep laceration, which was extending from temporal region of the scalp to the cheek region. So the facial nerve transaction was there, and which we can clearly see in this clinical photograph, where the frontal branch, temporal branch, zygomatic branch, and the buccal branches are affected. Also, malar flattening was there, which is linked toward the zygomatic bone fracture. CT findings suggest this en bloc, the fracture of the ZMC and its en bloc displacement of the fracture we can see, and also zygomatic arch was fractured. So combined surgery was planned with our plastic surgery team. At first, bony framework was restored, in which we planned the 3-point fixation and fixation at frontozygomatic region, zygomatic arch, buttress, and infraorbital rim was planned. And it was followed by the facial nerve repair, microsurgical suturing with nylon by our plastic surgery team. So these are the clinical intraoperative photographs where we can see fixation done at infraorbital region, the frontozygomatic region, the zygomatic maxillary buttress region, and zygomatic arch, which was approached by the existing laceration. And this picture depicts the the facial nerve repair, which was done by our plastic surgery team. All the temporal, zygomatic, and buccal branches were reapproximated. This is a comparison of pre and post-operative CT, where we can see the 4-point fixation done at all the articulation. Now, this is the comparison of pre and post for facial nerve function. We can see the patient after a period of 1 year post-operatively is able to close his eyes, and also the other buccal and temporal branches function regained. And this is the comparison of the scar. Now, this is a case of a 22-year-old gentleman with etiology of road traffic accident with a late presentation, that is more than a month. And he had the chief complaint of facial asymmetry, as we can clearly see in this worm's view. We can see the malar flattening is there and facial asymmetry. In the CT, we can clearly see there is bony malunion at the frontozygomatic site and also the infraorbital rim. So in such cases, we plan, first of all, we have to osteotomize the segment, osteotomize the bone, and then fix it in its accurate position. The exposure was planned by a hemicoronal approach and the subtarsal approach, followed by 3-point fixation. These are the intraoperative photographs. Here we can see first the after the bony union was separated. This is the fracture and fixation done at frontozygomatic site and zygomatic arc region. And this picture depicts the fixation at infraorbital rim approach through the subtarsal approach. And this picture depicts the soft tissue resuspension that has to be done for optimal aesthetic result of the patient post-operatively. This is the comparison of pre and post-operative CT, where you can see the 3-point fixation. The ZM buttress region was not restored because there was combination at that site. This is the comparison of pre and post, where we can see the malar projection is regained and facial symmetry is regained. This is a next case of 45-year-old gentleman reported with, again, RTA. It was a case of polytrauma and also had multiple bones of leg, and distal and radius was also fractured. So he came to us with all pertaining to all complaints. There was facial asymmetry with flattening over the right zygomatic or the malar prominence and restricted mouth opening. So this is the clinical CT photographs showing the comminuted fracture of right ZMC with marked posterior inferior displacement of the zygomatic body fragment. So initially, this patient was managed in emergency by orthopedic team for bilateral femur shaft fracture, where external fixator was applied in the first surgery, followed by nailing. Then after that, we planned, when the patient's facial edema subsided, we planned for ZMC repair. And for this patient also, hemicornal approach and right subtarsal approach was planned for a 3-plan fixation. This is the intraoperative photograph, where we can see the fixation at frontozygomatic, lateral orbital, and zygomatic body region. Here at arch region, here at the zygomatic body region, and This is frontozygomatic site. Here we can see the proper projection achieved after fixation. So now coming to the complex cases where first the comparison of pre and post, we can see facial symmetry of the patient is regained, malar prominence again achieved, and mouth opening of around 44 mm achieved post-operatively. Now, for complex cases, we use virtual surgical planning and 3D printing for managing our complex cases. For such cases, we need high resolution CTs where the DICOM data and slice thickness of less than 1 mm is needed. So this DICOM data is transferred to an to a software that we use 3D slicer. So here we segment the DICOM data is segmented and an STL model is generated. Here we can see. Now this STL model is transferred to computer-aided design software. We use a software named Mesh Mixer. And here, after we transfer the DICOM, the STL file, we mirror the normal side onto the affected side, and then 3D models are printed in resin, or we can also plan our surgical templates or implants. After planning, we have our in-house 3D printer where we print in the 3D models and splints in resin and then use in our surgery. So coming to the next case, a 19-year-old male with etiology of road traffic accident reported 14 days after trauma. She complained of unable to chew food and restricted mouth opening. Clinical presentation also shows there is an increase in the bizygomatic width. We can see the right side of the lateral midface width is more than the left side, and also flattening over the right side malar eminence is there. Also deranged occlusion, that's why the patient is not able to chew as the teeth are not occluding in proper position where they should. The CT findings show us comminuted fracture of the right ZMC and fracture at level Leafort 1, which is the cause of occlusal discrepancy. In this axial section, we can see fracture zygomatic arc and buckling of the arch, which leads to increase in bizygomatic width. Similarly, here we planned a 3D model of the patient's zygoma and lateral orbit, and the splint was designed. And intraoperatively, these intraoperative photographs here we see adapt mini plates before on the model and then to the fracture sites. So the fracture sites exposed by a 3/4 corneal incision or approach. Then we adapt the splint to check the reduction of the fracture segments, and then we fix the fracture with using the mini plate system. Following that, we readapt the splint and check the fixation whether it's proper or not. This is the comparison of pre and post-operative CT, where we can see a 4-point fixation done. And in this axial section, we can see the normal bizygomatic width is achieved, and this arch is restored back to its anatomical orientation. This is the comparison of pre and post-op. Here we can see both side midfacial width is now restored and is equal bilaterally. The malar projection is again achieved bilaterally. Mouth opening has again improved from 17 to 40 millimeter, and now the teeth are also in proper occlusion or contact with each other, so the patient is able to chew. Another case is of 50-year-old gentleman with a history of road traffic accident with chief complaint of restricted mouth opening and unable to chew. So here also we can see facial asymmetry and edema on the right side of the face, reduced mouth opening, malar flattening is there, and here also occlusal discrepancy is there because of the fracture of maxilla and palatal split is there, which we have managed here temporarily with a wiring we call bridle wiring. So the CT scan of the patient shows right ZMC fracture with comminution at infraorbital region here. In infraorbit, and also the arch. We can see that arch is fragmented into 3 parts. Also the fracture of right maxilla at leaf foot 1 level is there with split palate medially. Also, we can see the orbital floor here is fractured, but the medial wall of the orbit is intact. So treatment planning, coming to treatment planning, a 3D model of the right ZMC and orbit was made by mirroring, then exposed all the malunited fracture by hemicornal approach and subtarsal approach, followed by 3-point fixation and orbital floor reconstruction using titanium mesh. Here we can see the exposure of the fracture segments, fixation and checking via fabricated splint. And this is the orbital floor reconstruction with the used mesh we can see. Comparison of pre and post. The clinical picture showing the patient regaining its facial symmetry, the malar prominence being restored, and mouth opening being increased. Coming to our next case, the case of 37-year-old lady who reported to us with a case of with also instance of a road traffic accident. She was unable to chew food, had diplopia, and gross facial deformity was there. We can this patient was sutured somewhere outside and was reported to us. We can see there is maceration of soft tissue at the lower and the lateral orbital region. Now, in this first facial picture, we can see there is hypoglobus and telecanthus present. And in this worm view, we can clearly see anophthalmos and malar flattening is there. Now, this patient had presented with active CSF leak and also developed symptoms of meningitis. So she was managed in collaboration with our neurosurgery team, where Lombardine and anti-meningitic prophylaxis was done for the patient. Meanwhile, at this time, because the surgery was getting delayed, so we, at least to get the maxillomandibular components in its proper orientation, we did close reduction of the patient, which we can see here, arch bar and intermaxillary fixation was done so that the jaw components are in its reduced state. The CT finding clearly show there is comminuted fracture of right zygomaticromaxillary complex, right infraorbital rim with orbital floor, right nasoorbital ethmoid fracture was also there, and fracture at leaf foot 1 level was there. In this coronal section, we can see the medial wall of the orbit and the floor was also involved. Here in the axial section, we can clearly see the medial wall fracture of the orbit. Coming to the treatment planning, initially the patient was managed by a neurosurgery team. Then after stabilization, we planned the patient for open reduction internal fixation. A 3D model again was made by mirroring of the normal side. Then exposing the fracture sites via hemicornal approach, existing laceration and intraoral approach was planned. Then fixation with mini plate system was done and finally the orbital floor reconstruction was planned with this pre-adapted anatomical mesh. Normally these anatomical meshes are available, but these also need some fine tuning. So we use the made model for that. So we can adjust and adapt it perfectly over the model itself at first and then inserted the patient. These are the intraoperative photographs. We can see the fixation done at the zygomatic body and infraorbital rim. Here we approached by exposing through the existing laceration. Fixation is done at the right lateral piriform region and left nasal base region with intraoral incision. Then fixation done at zygomatic arc and frontozygomatic region by the 3/4 corner approach. And here we can see the orbital mesh, which is placed and secured here with two screws. Then following the bony repair, the soft tissue suspension is important. Here we can see the soft tissue suspension done using ethibond sutures. This is the comparison of pre and post-operative CT, where we can see all the points where the fixation is done for this patient and normal projection of the zygoma is achieved. This is the comparison of pre and post, where we can see the bilateral facial symmetry is restored and malar prominence is also restored. Now the patient, for its lower eyelid lower shortening is under follow-up with our ophthalmology team, and they are planning for some oculoplastic procedure for the same. And this is the last case I'm going to present is of a 17-year-old girl with a history of road traffic accident, and she also complained us with facial asymmetry and diplopia. The patient's surgery was also delayed, whereas the patient was on inotropic support for a long time. Then after stabilization, she was managed by us by ORIF. In the emergency room, the primary repair of this lower eyelid lacerations was done by our ophthalmology team. Here we can see the patient chief complaints, restricted mouth opening, significant anophthalmos that we can appreciate in this bird's eye view and also in this worm view. Here we can see the en bloc displacement of the right ZMC laterally and inferiorly. Also in this patient, there was fracture at the orbital floor, which we can see here in this sagittal section. Medial wall fracture we can appreciate in this axial section, and in this corner section we can again here see the orbital floor being fractured. Here also 3D model was made for fine-tuning and pre-adaptation of the or implants, followed by fixation with 1.5 and 2 mm mini plate system and orbital floor reconstruction. Exposure of the fracture by extended transconjunctival and lateral canthotomy approach. Then this is by hemicornal approach, the closure of fracture. Fixation done at art and body region. There's fixation done here at the infraorbital rim and orbital mesh placement and fixation. Here you can see. This is the comparison of pre and post-operative CTs of the patient, where we can see the 3-point fixation and the orbital floor reconstruction. And we can see that the orbital floor is reconstructed. Here we can see in this corner section, this orbital mesh, and also here the floor is stored. Now, post-surgery, the patient also went for some scar revision surgeries by a plastic surgery team, and these are the pre and post-operative comparison of the patient, where we can see bilateral facial symmetry is regained for the patient, and also the malar prominence is there. However, the patient is still having some amount of anophthalmos, as we can see here, for which she is being planned for patient-specific implant by our team. She is being planned for that to restore. And with this, we complete our case presentation, and now I request our respected sir to please take over.
To Dr. Surendra. So the take-home message from today's presentation is the lateral midface fracture, especially the GMC fracture, they constitute a significant trauma burden. Recently, we have seen a change in the pattern of these fractures with more and more complex and comminuted cases. This could be because of better road infrastructure and better highways, which results in high energy trauma. Now, to achieve optimal outcome of these fracture, it requires accurate diagnosis, proper classification, and customized fixation strategies depending upon the patient's need. Since there is a rise in high energy trauma these days, which these fractures often involve adjacent areas and require collaborative care, especially with involvement of our plastic surgery, ophthalmology, and neurosurgery team for comprehensive management of these injuries and improved outcome and reduced complication. Obviously, the virtual surgical planning significantly enhances the precision and predictability. At present, we are using open source software. These are a little bit difficult to work on and also have some errors, but it is always good to have some guidance intraoperatively that will reduce the intraoperative hassle and improve the surgical outcome. So, looking ahead, we are planning to establish our virtual surgical planning lab, and probably very soon we will also have intraoperative navigation and intraoperative imaging facility at our center, which will further enhance our surgical outcomes. Thank you.